Yes. My question is to Dr. Cragg and also Dr. Samir. You had shown in your chart that the risk of cirrhosis with each of the risk factors in terms of steatosis, alcohol consumption, etc. At the top was the highest jump in risk, and that came from PNPLA3 homozygous to heterozygous to homozygous. The biggest jump came from that particular change in just the PNPLA3 status. So what is the actual percentage of population who are PNPLA3 homozygous in, say, in the West and in India?
Thank you. So the carrier state, I think it's highest in South America. I think that's 30 or 40%. I think in Europe it's a bit lower. I don't know the Indian. So many would expect, and that's also I think the direction we want to go, because if you know that this is such a strong component, we do measure PNPLA3. It's a single SNP. So that's not too difficult or too expensive to measure. But of course it depends on the, but I don't know, Dr. Shah, do you know the frequency of the carrier state in India?
No, it's not the carrier state, the homozygous state. That was what I was
So homozygous is much less than heterozygous. Heterozygous would be 20 to 30%. Homozygous would be less, around 5 to 10%. But I think the important thing is what do you do with the PNPLA3's sort of positive report? So I think that is the key question.
But I think you answered that very well, because then you know you have a very high risk patient. So you cannot yet change the gene. When these drugs come out, you can. But for now, you know that you should leave none of these cardiometabolic risk factors unattended, and you should definitely motivate them also for their alcohol consumption. So I think that is, this is specifically, so also see, when should you see this patient again? Okay, you're a high-risk patient, I need to see you more frequently and motivate you to do and follow all these things. That's the way I would use it, as a risk, as a really a risk thing.
I think I would support that. It just gives you another tool for the person to give up alcohol and for the person to diet and exercise. I think that is the way, as of now, we should be using it, because it definitely adds on, as you rightly pointed out, to the risk factors, and it would add on to the sort of polygenic risk score, because that would come in also. Interestingly, as I was mentioning in my talk, in alcoholic liver disease, if you add diabetes to it, in the polygenic risk score, suddenly the positive and negative predictive value of the score goes up by just adding diabetes to the rest of the factors. So I think this is just underlines the metabolic risk factors addition to the genes.
Microphone 3.
Yeah, I'm not convinced that adding MET SLD make any difference, because first of all, we cannot assess the quantity of alcohol patient is taking. And is there a long-term study to show that a little bit amount of alcohol to MSLD make any difference?
Yes, they actually are. And I think so our study there was based on self-reported alcohol. Now we're repeating PEth, you know, the thing that reflect alcohol consumption to 3 to 4 weeks in thousands of patients to validate all these things. And it actually, in our hands, at least in our sake, doesn't look too bad to just ask. But then I think also the outcomes of us were clearly different. But there's a paper that was just released 2 weeks ago in Journal of Hepatology addressing exactly that question. And I think there are other papers out. That was with 3,000 patients from Spain. And they could clearly see, if they took the MASLD spectrum and say that those that drank nothing versus those that were just below the cutoff of 20 or 30 grams a day had a much higher percentage of more advanced fibrosis. And it also made good sense, because I think if I had a BMI of 35, type 2 diabetes, and drank 3 units a day, it's kind of logic with what we know versus I drank nothing. But that is some of the data that is coming out. And again, there's also another study just coming out here, I think last week, from Finland, confirming our studies with 21,000. That was more population-based study. So I think it is, what I'm saying is supported by data. And also with this interaction, I think our efforts to reinforce anything that can reduce alcohol consumption in these patients are really important because it's so dangerous for them if you also have diabetes and overweight.
But if you advise your patient not to drink alcohol at all, when he
But
has
that's
metabolic associated liver disease,
Yet,
then
yet
that's all, and then your level keeps changing. You know, sometimes is 50 grams, then is 60 grams, then is 30 grams. It keeps changing.
yeah, that's the problem. But there are these studies. There are at least 2 nice studies. One from Austria. They had a big population. They were all diagnosed MASLD. Then they measured these markers. Almost 28% had signs of alcohol consumption. 10% have signs of high alcohol consumption. But because they were underreporting, another Swedish study found that if they just look at diagnosis code, 17% of MASLD were wrongly diagnosed. That's why I think implementation of these biomarkers is important, because otherwise, as you say, we will go wrong, and then we forget to have them. And I think it's not just about black and white, drink or not drink. I'd say them any reduction. Maybe people cannot stop completely, but if you can go from 10 units today to 5 units, or we go from 3 to 1, or have days off.
Thank you. Microphone 2.
One question for Dr. Sindhu. Do you see any role for FMT in severe alcoholic hepatitis? Because you didn't mention in your talk. And some studies from ILBS show that it is as good as steroid or better than steroid.
I purposely did not point out two studies that have happened only in a single center. There are many several studies like this, single center studies which have shown in a small number of patients improvement. But on the whole, there is not great amount of data around the world which shows that this is a very effective form of therapy. Probably yes, in a single center, it deserves probably mention, but as of now, there is no other center that has shown a significant improvement.
In steroid non-responsive patients?
The same question comes, whom do you call steroid non-responsive? How do you label them as steroid responsive in the first place? Whom are the patients whom we would happily give steroids? In most of our academic centers in India, we do not give steroids to our patients. The reasons are obvious, like I said before. Our patients are malnourished, they are sarcopenic. You give them steroids, we are lighting up a fire of sepsis in them. So therefore, giving steroids to these patients is not the norm in most academic centers.
This is a question for Dr. Sidhu. We all know severe alcoholic liver disease patients are always deficient in their nutrition. At my center, after assessing their nutrition for 2 days, we put in a nasogastric tube and then we feed the patients aggressively, more than 2,000 calories a day. And even when they are going home, we've sent the patient home with a nasogastric tube. And I find that this works pretty well because most of them are very much calorie deficient, and we all know that nutrition is one thing which certainly works in these patients. So what's your comment on this?
The comment on this comes from actually a study from published in Gastroenterology in 2016 by Dr. Moreno's group. It was a negative study. They showed that nutrition versus steroids did not improve the mortality. But an editorial to that study by Dr. Mark Thurs and somebody from the US, Puneet Puri, had suggested a couple of things. One is, it was found in this study that anybody who was taking less than 22% of less than 22% calories, kilocalories per day, were having a much higher mortality. Number two, they also pointed out that if your intake of lipids is more than 66 per day, 66 I think kilocalories per day, and proteins is around 77 or 76. If you take this much amount of proteins per day, then grams per day, then these patients have a much better prognosis in these patients. So I completely agree with you that I think nutrition is an underplayed role in our patients. Yeah. We need to be aggressive not only in giving them treatment orally or by enteral route, but also the dietitian or the nutritionist needs to see those patients the next day, whether have they really taken that stuff or not. In a lot of cases, on the ground base, you will find that whatever you have ordered has not been taken by the patient, even only 20% has been taken by the patient. So it's very important that a good nutrition is in order. At the same time, you need a nutritionist, or you yourself will have to monitor that nutrition, that number of calories, proteins have been taken by the patient or not. Lastly, has the patient taken a night snack of 700 kilocalories? These things I didn't point out, but the fact remains that these are very important things that we can practice in our patients if we do not have any other thing to offer to them. Thank you.
Yeah, I completely agree. Thank you.
So one question to Dr. Craig. Dr. Craig from here. So you mentioned about the potential use of rifaximin and some probiotics. So we use it for everybody, or we do a fecal microbiome study to see who is going to benefit? That is first question. And the second, how far are we really from the siRNA based therapies about for PNPLA3? We talk a lot about it. So is it going to be a reality in the near future?
Yes. So I think for ours a phase 2 trial, it was primary endpoint was negative, so it needs to be repeated. And again, I think today going forward with an antibiotic is probably not so attractive. So I think we rather want to do something where you modify the microbiome, and the more specific we can do, finding individual changes, that is probably the way forward. So that's trying to analyze that. And then I think with sRNAs, that is happening now. These drugs are already available. They've been tested in phase 1 trials, and I think for the sRNAs for HSD is already being tested in ALD and MASH, and it will also start soon in alcohol. So that will be a reality, and then see how it plays out. But I imagine they will fall out positive, and then we will see.
So thank you very much. Thank you all the speakers and all the chairs. It's been a great session, and we leave the stage to the other session.